By now, we all know that America is the most dangerous place to give birth among wealthy nations and that it is only getting worse. What we don't talk about enough is the national crisis involving unnecessary induction that is harming many women and, in many cases, causing irreversible physical and mental health damage, including postpartum psychiatric conditions. Let me remind you of our national statistics if you think I am exaggerating. Annually, at least 1 out of 3 pregnant women will undergo inductional labor, and another third will end up with cesarean sections. Those are dismal numbers for a country without a national paid maternity leave and universal health care. No wonder so many women are on medications for anxiety and depression. Don't you think that the other crisis involving obesity among women is related to poor pregnancy experience? Of course they are. We not only support pregnant women inadequately during pregnancy, but we also coerce them into an unnecessary, artificial, poorly understood process called induction of labor to end up with a lousy experience and outcomes, which in turn affect them for a lifetime. This national abuse is unlikely to reverse anytime soon. I mentioned that 95% of women who plan home birth will deliver vaginally, whereas only 65% of women laboring in traditional settings such as hospitals and birth centers will deliver vaginally. 95 versus 65%. That's like getting an A plus versus a failing grade. I can tell by the reaction that many of you are shocked. First of all, only 1% of births in the US are home birth. I support home birth, but this comment was not to promote home birth, but to point out that women who plan home birth do not undergo induction of labor. It is that labor induction that causes more harm than good, in my opinion. To clarify, I'm talking about unnecessary inductions without clear medical indications, such as elective inductions at 39 weeks. This unfortunate trend isn't just in the US, but worldwide. Mother Nature isn't perfect, but she beats science hands down. We don't understand the physiology of labor completely. We may have driverless cars, robotic systems for surgery, and spaceships, but we don't know when or how labor starts. I don't understand why so many unnecessary inductions are taking place. At least in the US, this trend may be due to a few things, including fear of liability and greed. With any maternal diagnosis, such as gestational diabetes or hypertension, providers will schedule induction on the earlier side of the recommended guideline. For example, ACOG, or American College of OBGYNs, the leading governing organization for my specialty, recommends induction of labor may take place between 39 to 40 weeks and 6 days for gestational diabetes controlled by diet. That is a 2-week window during which a lot could happen. Maybe spontaneous labor will start. Most providers, however, will schedule such induction at 39 weeks rather than 40 plus weeks. For providers, once a diagnosis is made, getting the induction started means that the provider's potential liability is minimized or washed. Who cares if a 35-year-old first-time mom who got pregnant through IVF after years of trying goes through days of cervical ripening just to have a cesarean section? Let's talk about the induction process briefly. Induction of labor changes the process of labor that Mother Nature had intended in many ways. It is a poorly understood artificial process, a hit or miss. Induction of labor usually involves cervical ripening and Pitocin given intravenously. Often, especially women who are pregnant for the first time, will need cervical ripening before Pitocin can be used to cause contractions. The cervical ripening process, whether chemical or mechanical, is a process that we have yet to perfect it. It may take days. Oxytocin is a hormone secreted by your brain to stimulate the uterus to cause contractions. Pitocin, which is a synthetic oxytocin, causes contractions but more pain than natural oxytocin. Continuous fetal monitoring is mandatory to monitor contractions and the baby's heart rate pattern to make sure everything is going smoothly. Between the monitoring and IV, you become less mobile. A big part of early labor pain management involves ambulation. Endorphins, the body's natural painkillers, are chemicals released by your brain and nervous system that alleviate pain, lower stress, improve mood, and enhance your sense of well-being. With spontaneous labor, endorphins are released to help manage painful contractions. Pitocin, however, does not cross the blood-brain barrier, so your body's natural response to pain is not triggered, hence no endorphins. Without endorphins, women undergoing induction are more likely to need an epidural for pain management. I find that often epidural is placed too early in labor, causing prolonged labor. To clarify, once you get an epidural, you cannot get out of bed or eat or drink. Again, you become immobile. Imagine getting the epidural when you are only 2 centimeters dilated because of pain. You may still be a day away from the delivery. And guess what happens with prolonged labor management done by a few providers? That is the perfect scenario for cesarean section. You will be told that no significant progress has been made, or you have a slight fever, which may become a full-blown infection, or the baby is not tolerating all the mucking around for days. A cesarean section will be mentioned, and by now you are tired. You just want it done. This scenario happens way too often. The bottom line is that while Mother Nature is imperfect, she knows something about labor. Let's return to the original provider who started this chain reaction for labor induction. The provider says, "Oh well, I tried. At least she has a healthy baby." This shit happens all the time. Had this same patient been allowed to be monitored and waited for a spontaneous labor, a 2-week window in the case of gestational diabetes under controlled diet, she probably would have delivered vaginally. Her postpartum recovery would be so different than having a cesarean section. She is less likely to suffer from postpartum depression and anxiety, and she probably will have an easier time with breastfeeding. So, why are providers so impatient? Did I mention that doctors don't get paid until you deliver? Oh yeah, they also get paid more for cesarean sections. How about hospitals? Could hospitals make an effort to reduce the overall cesarean section by not allowing improper inductions as well as implementing protocols to reduce cesarean sections? Why would they? Since greed is a big part of medicine in the US. The difference between 100 vaginal deliveries and 100 cesarean sections is $2 to $3 million. No CEO or CFO will do anything like that to lower the revenue. I will not convince my colleagues to change their practice patterns. I am sure I could not influence hospitals to make any changes, and I am confident that entities like ACOG, which supported that unfortunate ARRIVE trial, which promoted elective induction at 39 weeks, will pay any attention to me. So what is the solution? It is you. I'm going to educate you to understand that in many cases, induction may not be necessary. If induction is indicated, you may be able to wait to see if you go into labor by being monitored closely. A matter of few days could mean a vaginal delivery versus cesarean section. So get educated. Let me help you. On this Instagram account, the most asked question by all of you is about the induction. More specifically, should you be induced or not? How desperate are you to ask a stranger, someone you have never met, if I agree or disagree with your doctor? You often ask me such questions within a day or two of the scheduled induction. And I have said, in most cases, I'm afraid I have to disagree with the management. I know I am repeating myself over and over. Let me help you.